Okay, I guess we're live. Hi, Elliot Fishman here, and today is the 28th of March. Hope everyone's doing well. This will be our last talk in March. April 1st is next Monday. For those of you who celebrate, Good Friday is tomorrow. Happy Good Friday, and I guess Easter Sunday must follow. For those of you who do Passover, well, you got about a little more than 3 weeks to wait. It's one of those years where Easter and Passover do not overlap, don't even come close. Anyway, hi John from Body CT. Um, anyway, this is on colon cancer screening. So it's colon cancer month, or so I thought I would at least talk about that from a radiology perspective. Now, if you go back to when many of us were trained, we did barium enemas, and that was the way you did screening for colon cancer. You may have done a cold stool blood for a screening, but then there was barium enemas. Barium enemas were good, and then remember it went from regular barium enemas to double contrast barium enemas. Igor Loffer was the important person there. You would coat the colon looking for small polyps. And it was a technique. It took a while to learn. It wasn't the most comfortable thing for the patient or for the radiologist, especially the technologist, but it was pretty successful in the right hands. A lot of inter-observer variability, of course, but all of us, did lots of fluoroscopy studies. I don't want to exaggerate, but I think most of you would agree that in one day during our residency, when we were running 2 or 3 rooms of upper GIs and lower GIs and everything in between, we probably in one day did more fluoroscopy than a resident today will do in their 4 years of training. So it definitely is a lost art, and it's an art that's not coming back. Okay, so radiology does have a history of doing screening for colon cancer. If you fast forward, CT came along. We use CT for staging colon cancer, looking at the liver, looking for nodes. We would pick up colon cancer at times. Sometimes there was a challenge between colon cancer and inflammatory disease, particularly diverticular disease or diverticulitis. But we did a lot of work in that regard, but it wasn't like we were going in there to rule out colon cancer unless it was, looking for obstruction perhaps, or big mass. And it was only when virtual colonoscopy came along a number of years ago, probably well over a decade ago, where what you were doing was, in some sense, going back to the days of colonoscopy. Prep the patient, classic fluoroscopy rather. You go, you prep the patient, you then, instead of with barium, you distend the patient's colon with air, which quickly became CO2. And then you would look supine and prone if the patient's colon was well prepped, seeing a polyp around a centimeter or so, and be able to then send the patient to colonoscopy for removal. So virtual colonoscopy came along. Now, the problem with virtual colonoscopy, a lot of it was dependent on the patient prep, which is challenging. A lot of it is also dependent on the site you're doing it at. We switched from air, where you would blow up a little balloon like this for 100 times, it seemed, and patients were very uncomfortable. With CO2, patients are more comfortable, it gets absorbed, so you don't have problems with the really bad discomfort people would have with room air. The problem with virtual colonoscopy, let's be frank, nobody likes to do it. The techs don't like doing it. No one likes putting the rectal tube in. It's prone, it's supine, it's a lot of images to look at. It'll take you 15 to 20 minutes with experience, and nobody wants to read the studies. Nobody wants to do them, and nobody wants to read them. So it's poorly reimbursed, I'm told. So when you have all of those negative things, it's not been a big growth area. People like Perry Pickard has done a great job in Wisconsin, but even at meetings, it's no longer spoken about because people just don't care. People really don't want to do it. But it is something we do. Probably we do 4 to 6 of them a week. Most are outpatients, a few are inpatients. But getting people to read them, it's only a couple of us, and um, people don't really like doing them. So I don't think it has a future. Let's be frank. It's just something you can do, and usually it's patients who can't get colonoscopy, classic colonoscopy. They get virtual, not always. Then we have classic colonoscopy. Classic colonoscopy was probably 80% accurate. Um, People would miss polyps. Colonoscopy, again, you need to prep the patient, which is not the greatest thing for the patient. But the patients are sedated, and so they really don't feel the process that's going on. There's a small risk of complications from perforation, complications particularly if you do a biopsy, but it's small. In good hands, accuracy, as I mentioned, 80 to 90%. One of the things that's changing with colonoscopy, excuse me, is I think Medtronic and Boston Scientific are working with AI. So now not only are you going to have the colonoscopist looking at the study, but AI is going to look at the study in real time. And it's been shown in the few articles I've read that you go from 80 to over 90% accuracy. So if you ask me where colonoscopy is going, it's really AI. Now, are you going to use AI for virtual colonoscopy? I guess theoretically you could, but if nobody wants to do it, no one's going to put the effort in for AI. You don't have quite the data sets to really train, but it's more the fact people don't want to do it, and AI is not going to change that. But for classic colonoscopy, AI picks up more lesions, and AI is also being used to determine what the lesions are, what lesions you need to biopsy, what lesions you need to remove, and it's actually speeding up the exam. We're surely not slowing the exam down, and it has the potential of making an okay colonoscopist into an expert colonoscopist. The typical thing AI does, it raises the bar for everybody. So I think colonoscopy, classic, always had a bright future, is not going away. The biggest challenge most places have is not enough people doing colonoscopy, but hopefully with AI you'll be able to do it faster perhaps and do it better. So that becomes very, very exciting. The other big area is on giving different agents, in some senses like doing the equivalent of liquid biopsies. The big company Cologuard, which is Exact Sciences, which I do work with on liquid biopsy, they've been the one around for a while. High predictive value of someone having something if the Cologuard study is positive. It does have false positive, it has false negatives, but when you think about it, again, it's something, it's an easy study to do. There's no prep or anything else. So a lot of people are using Cologuard as a way of doing, and if your Cologuard is negative, very high accuracy when it's negative. So I think that's a very good way of going. People also with liquid biopsies, one of the big areas of liquid biopsy, whether it's Illumina, Exact Science, or other places, is going to be able to predict colon cancer early. Then you do colonoscopy and you take it out. So I think where things are going with colon cancer screening is going more to the liquid biopsy and AI with classic colonoscopy. I have a feeling that long-term virtual colonoscopy is just not going to be used unless it's someone who can't go to colonoscopy, they can't be sedated, whatever the reason is, or they can't be prepped. But again, when you give us the patients who are really bad or can't cooperate or can't be prepped, we're not going to do very well either. So I think we're all going to continue to do virtual colonoscopy, but it's not something that any of us really want to grow, and none of us really are that excited about. Now, maybe if you're excited about it, just tell me and we'll give you some credit. But I think it's just not really a big growth area, but that's kind of the reality of the situation. But again, colon screening is important. I think people are going to start looking, particularly with things like Cologuard and liquid biopsy, about maybe screening people earlier. You know, one of the things you've read about, you know, it used to be colon cancer screening was age 50, then some people said 40, 45. But there's a lot of reports now of younger patients, particularly women, getting colon cancer in their 30s. And it's not like it's hereditary, like familial polyposis or one of those syndromic type things, Lynch syndrome, things like that. It's just out of nowhere, people are getting colon cancer earlier. So I think things like liquid biopsies perhaps will be done earlier. Perhaps things like Cologuard will be done earlier. So I think a lot of people are thinking about how to do things. But I think screening for colon cancer, do not misunderstand what I said, needs to be done. It's very important you follow the rules, the guidelines, whether it's every 5 or 10 years for colonoscopy, your family history, your personal history, and everything else. The question to me is going to be, how is screening done? I think long-term liquid biopsy, things like Cologuard leading the way, classic colonoscopy using AI will be much more accurate, so you're going to be able to repeat the studies less frequently, I believe, and patients will get better care. So with that, if you want some references, I'll be happy to give them to you. But we will be doing virtual colonoscopy for a while, so we're going to put some of our latest protocols for that online. And with that, I wish you a great day. See you later.